This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Fellows Conference. Dr. Fernandez is going to be our speaker this morning. He is a first-year clinical fellow in our ABIM research track. He did his medical school at University of Alabama, Birmingham, came here for residency and did 3 years of basic science research. And as you can see, he's going to talk to us today about pulmonary hypertension. Take it away, Tim.
Thank you so much for the introduction. Good morning, everyone. Today, my slides are on not forgetting about the right side of the heart, and we're going to discuss pulmonary hypertension, especially as it pertains to us as cardiologists. And so just as a brief outline, I want to introduce our case this morning. I'm going to define pulmonary hypertension and discuss the pathophysiology behind the disease. Look a little into the diagnostic criteria and just the workup into thinking about pulmonary hypertension from echo, right heart cath, and more specifically, especially as us as cardiologists, looking how we differentiate between group 1 and group 2, since I think we're going to be consulted a lot about that, and discuss the current treatment options as pertains to group 1 and group 2 from the WHO classification. And very briefly talk about a new investigational therapy that's recently come out. I have nothing to disclose this morning for this presentation. And so what we have here is a 50-year-old female diagnosed with a mixed connective tissue disorder. Apparently it's a sclerodermal predominant type, hypertension, acid reflux, and she had presented a few years back with shortness of breath. This all started in 2020 after a car accident. Maybe was thought to have some ambulating just because of the car accident. So she hasn't stopped working out, became a little out of shape, gained a little bit of weight. But she started noticing later on the next year some joint pain, acid reflux, myalgias, and eventually this led to her the diagnosis showing that she had this mixed connective tissue disease. However, despite being put on these inflammatory medications, she still started noticing she had trouble walking long distances. It got to the point where she ended up needing to use a motorized shopping cart at the grocery store just to get around. She could walk around her house without assistance, but she ultimately had been avoiding all the stairs in her house just because it ended up making her fatigue and she'd have to stop halfway. And so just because of this progressive dyspnea, sought help, came to the emergency department in December and was worked up for further evaluation. No chest pain, syncope, no history of blood clots, snoring, sleep apnea. Maybe she had some swelling in her legs. Other things to complete her history, she has hypertension, well controlled on these 2 medications, HCTZ and amlodipine. No pertinent family history other than hypertension. And at least from a social history, no illicit drug use, no smoking. Specifically, they asked for no weight loss drugs, no illicit drug use, and not currently sexually active. On exam, thought to be tachycardic, but blood pressure is relatively okay. Things that they did appreciate, they didn't see that she had a JBP, at least on their exam, but at least what was noted in the notes back then, had a 2 out of 6 holosystolic murmur, best heard at the tricuspid area, and maybe some trace edema to the level of her shins. Otherwise, nothing on exam that they could appreciate. Maybe some skin changes consistent with the scleroderma. And at least to complete her labs, noted to have a BNP of 191. Her UDS was negative and a slight elevated high sensitivity troponin at 35. She got an EKG when she first came because of the shortness of breath. Looking at it, looks like sinus tachycardia. Looking back in the ED notes, they thought maybe could there be some concern for an S1Q3 T3 pattern. They can see a little bit of an S here, a little bit of Qs and 3s, but really some flattening of the Qs. And so, but otherwise, no other ST changes. And of course, this is prompting them to get the CTP pretty quickly. She did get a chest film, which we can appreciate. Granted, this is a AP without the lateral. Noted to have some enlargement of the heart. I think you can maybe start to appreciate a little bit of a bootleg pattern to the heart, but otherwise nothing else. She did get the CT pulmonary embolism protocol. There was no PEs noted, at least to the level of the segmental level. However, did note to have a dilated pulmonary artery about almost 4 centimeters, and signs that this could be related to like a pulmonary hypertension picture. And so this kind of starts the workup for this patient. And so let's take a step back and think about pulmonary hypertension. The WHO has 5 groups that they classify it into. Group 1 is pulmonary arterial hypertension. This could be from idiopathic causes, heritable causes. A lot of times in young females, or it may be from like drug or toxin induced, whether it's amphetamines or weight loss drugs. And a lot of times noted to be associated with other diseases such as connective tissue disorders, HIV, portal hypertension. Group 2, which we'll see a lot of, is due to left heart disease, whether that's from systolic dysfunction, diastolic dysfunction, valvular disorders, congenital heart disease. And group 3, we classically attribute to lung diseases, hypoxia, whether it's obstructive or restrictive lung diseases, hypoventilation syndromes. Group 4 from chronic thromboembolism, pulmonary hypertension, and group 5, which unclear multifactorial mechanisms, could be mixed. A lot of times it's systemic disorders, metabolic disorders, chronic renal failure. One thing I wanted to highlight, the European Society recently came out with guidelines this past August of 2022 and made some changes to at least to some of the classification. One thing in particular, the idiopathic pulmonary arterial hypertension is further subdivided into non-responders to vasoreactivity and acute responders to vasoreactivity. Additionally, I think they're classically we thought that sleep apnea, you may see like here, is like sleep apnea is not like particularly noted, but it's actually like grouped into hypoventilation syndrome. Like sleep apnea alone doesn't cause pulmonary hypertension without noted significant hypoxia from the hypoventilation or without significant CO2 retention. And so that's why it's ultimately was classified as a hypoventilation syndromes. So in a patient who has pulmonary hypertension, they're further classified into their actual functional class. And as you can see here, subdivided into 4 classes, very similar to the New York Heart Association. And so class 1, they're relatively symptom-free, doing their normal activity or resting. Class 2, some normal activities may cause some discomfort, whether it's grocery shopping, going upstairs, can cause shortness of breath and some chest discomfort. Class 3, resting, they're symptom-free, but even their normal day-to-day activities, just getting around the house, doing their chores, patients are very, very limited by their shortness of breath and feeling tired. And class 4, even at rest, they have severe symptoms with any activity. And I think looking at our particular patient, it seems like granted this is a pulmonary hypertension talk, likely seems to be consistent with like at least class 2 symptoms as of right now. And so looking at the pathophysiology, it's not an easy feat, but broadly speaking, here we have the 3 layers of the blood vessel, the pulmonary artery: the tunica media, tunica externa, tunica intima, or it could be further classified as the endothelial layer, the smooth muscle layer, and the adventitia of the vessel itself. And particularly in pulmonary arterial hypertension, there's dysregulation at all 3 levels of all 3 layers of the vessel. You have vasoconstriction of smooth muscle cells. This can lead to a decreased nitric oxide, increased prostaglandins, and the increased activity of the endothelium. Ultimately, there can lead to changes in the fibroblastic levels externally, and as well as inflammatory cell infiltration, inflammation. This leads to a vessel that ends up stiffening because you end up having smooth muscle hypertrophy. Even at the endothelial layer, you have smooth endothelium proliferation, leading to even further fibrosis. This backtracks and causes dysfunction in the whole pulmonary artery circuit. And this backtracks, leading to worsening RV remodeling and ultimately right ventricular failure. And so when we have a patient who comes in with shortness of breath, we may have an inkling there could be pulmonary hypertension. Their symptoms can be classified as early or late. The European Society really outlines these symptoms very beautifully. And so early on, of course, we'll notice symptoms of dyspnea on exertion, maybe fatigue with rapid exhaustion, some palpitations and weight gain. But later on, once we have worsening pulmonary artery dilation, this could lead to exertional chest pain, syncopal event, shortness of breath, even like hoarseness, because of just how enlarged the pulmonary artery gets, can lead to some dysphonia. There's compression of the left laryngeal recurrent nerve. And so on physical exam, things that we may see, at least on auscultation, murmurs from tricuspid regurgitation, pulmonary regurgitation. You may appreciate a accentuated pulmonary component of the second heart sound. Signs that the RV is having some backward failure. You can see the peripheral edema, hepatomegaly, may appreciate the JVP. And so things that you want to look on exam are things that may point you in a direction that may further classify the patient's, the underlying cause of the patient's pulmonary hypertension. So, and someone may have signs of a DVT or signs of connective tissue disorder, signs of clubbing that may point to like lung disease. And overall, these are some findings that may lead to your diagnosis. The ESC also guidelines talks about some imaging findings as EKG findings that may point you in a direction. At least from the EKG, you may see signs of a new right bundle, right ventricular hypertrophy, and at least signs from the imaging standpoint, you may appreciate, could there be signs of COPD or chronic lung disease that may point you in the direction, or how the heart is looking at itself. But ultimately, what happens when we get a patient getting worked up for pulmonary hypertension, whether they're going through the ER, going through their primary care physician, they'll start with this workup. They'll look at the patient's history, physical exam, EKG, may get a BNP, and there may the ESC nicely outlines, okay, so are we thinking, is there a cardiac cause to a shortness of breath or a lung disease cause of the shortness of breath? And I think, especially if we're going down the pulmonary hypertension route, ultimately it's going to all lead to the patient getting an echo. And so the European Society really likes to emphasize on the peak tricuspid regurgitation velocity. And this will give you a low likelihood, intermediate likelihood, and a high likelihood of whether this patient is having signs of pulmonary hypertension. And I think studies have shown that this is probably the most system-specific marker, at least from an echo standpoint, to at least classify your patients in one or the two categories. And so if you have a velocity less than 2.8, it's probably low. Greater than 3.4 is probably high. But of course, this is depending on how the valve is looking itself. You have to consider you may get underestimations of the tricuspid regurgitation velocity. And so ultimately, based on this, may lead to whether or not you need to look at an alternative diagnosis, repeat an echo down the line, or actually even go down, getting a right heart cath to actually see if the hemodynamics confirm with each other. And so if we look back here, after you get a decent tricuspid regurgitation velocity, it's also about looking at other echo signs of pulmonary hypertension that may lead you to think of this high, intermediate, or low probability. And so this is a beautiful slide. Ultimately, we can categorize into three groups. One, what is the right ventricle doing? Two, what is the RA IVC doing? And three, what's the pulmonary artery doing? And if some signs that we'll see is in the peristernal long axis, do we see in a large right ventricle, especially in the 4-chamber view, does it appear dilated? Looking at our short axis view, can we appreciate a flattened intraventricular septum? And what is the IVC looking like? Other things, looking at the RVOT acceleration time, anything less than 105 and with a mid-systolic notch could be indicative of a pre-capillary pulmonary hypertension. What's the TAPSE looking like in terms of the RD function? What's the right atrial size looking like? And again, going back to the velocities and corresponding to the IVZ size and collapsibility to give us an estimation of the right atrial pressure. So going back to our case, here is a shot of her peristernal long axis. And so I think things you can appreciate, the EF looks relatively normal, but looking at the septum itself, there's definitely abnormal septal motion. And looking at the RV itself appears maybe mildly enlarged, but definitely the systolic function appears to be down. This was probably the best shot that I saw of her tricuspid regurg. Maybe we'd probably increase this a little bit up here, but one thing you can appreciate is the Vmax around the 3.4 area, at least here, corresponding to a max pressure gradient of at least the mid 40s or so. And again, going back to the other slide, is in addition to having the peak, the tricuspid velocity, looking at, do you have at least two of the following categories to suggest that there's pulmonary hypertension: the ventricles, the PA-RV outflow tract, and the inferior vena cava and right atrium. Looking at any of these factors there. And so looking at her echo, and we can appreciate in the short axis view, she definitely has both diastolic and systolic intraventricular flattening consistent with volume pressure overload. Her acceleration time appears to be 85. I don't know if you can really appreciate notching in Savior. It's not as peak that you expect, but I think this, at least the acceleration time, is nothing to consider. In her case, she did have a very nice pulmonary insufficiency, at least the PI end diastolic velocity, which was measured at least here to be 14. Looking at here, anywhere it could be from 10 to 14, depending on what value you end up using to calculate. And then finally, looking at her right atrium appears to be enlarged. The estimated area size here appears to be 35, so definitely greater than 18. Looking at this echo, didn't have a great IVC shot, but at least when it was playing, didn't have any collapsibility. I don't know if you can say this is true of the IVC. It's kind of hard with this. I think there's a little motion artifact in here, but it appears to be dilated in this, at least looking at the other picture of the IVC. And so in summary, here was her official echo report. Other things to note is they had noted grade 2 diastolic dysfunction. She has a mildly dilated left atrium as well, with a moderately dilated right atrium, normal EF, but her RV size seemed to be mildly enlarged with mild to moderately reduced RV function. And at least based on all the numbers that we've seen, as well as the graphs, it appears that her right ventricular systolic pressure is measured to be around 63. If we were to use her PA end diastolic, it would end up probably being around the high 20s or so. And so we have a patient now, just to summarize, with what seems to be pulmonary hypertension based on her exam, based on her echo findings, based on some of the imaging, has a history of mixed connective tissue disorder, but also known to have diastolic dysfunction, maybe an elevated left atrium. So what can we say is the WHO classification? And I think us as cardiologists, we should be present to at least help guide the discussion. I think a lot of times we'll get consulted as oh, should we jump the gun, run to get a right heart cath because everyone's excited about all these pulmonary arterial hypertension treatments, and we should just start them on everyone. But if we were to take a step back, really only 2 to 3% of all patients who have pulmonary hypertension are true pulmonary arterial hypertension. The prevalence of PAH itself, it's only around 6. The incidence is around 6 per million, and the prevalence of PAH is about 48 to 45 per million total. There's not really a lot of the exact prevalence of group 2 pulmonary hypertension is not defined, but at least most echo-based studies that we've seen, you can safely say about 60 to 70% of all pulmonary hypertension is caused by left heart disease. One thing I wanted to specifically highlight from the European Society guidelines is that in patients who have a high likelihood of left heart disease as the main cause, and only having maybe mild pulmonary hypertension, we don't typically, the invasive assessment is not typically indicated. There's no need, there's less of a reason to get a right heart cath unless there's other things that we're working on. And so this brings me to the point where what is high likelihood, what's medium likelihood, and what's low likelihood. And this is probably based more from the 2019 guidelines. It's probably a little easier to delineate there. But patients who have sufficient left heart disease and have a high probability of it, usually greater than 70 years old, have factors of obesity, hypertension, diabetes, had a previous cardiac intervention, might have AFib, and like an elevated enlarged left atrium and tissue Doppler suggestive of grade 2 diastolic dysfunction. Usually in these patients, there's a high enough probability to explain the pulmonary hypertension, and a lot of them don't need a right heart cath. The patients who are intermediate, a little younger, have some of the same characteristics, but no, they don't really have like structural heart disease present. They only have 1 or 2 of these factors, maybe some grade 2 diastolic dysfunction. And we really don't know the impact of the left heart disease in these patients. And as such, it may be beneficial to get a right heart cath in them, especially if there's other factors involved. Like in our particular patient, she may have this who has mixed condition disorder. So we don't know how much is the left heart actually contributing. And then of course, low probability. These are the patients who are much younger, no other comorbidities, no signs of left heart strain or left heart abnormalities like EKG, echo, MRI. They should undergo additional diagnostic testing to look for other causes to why they may have pulmonary hypertension. And so for patients who we can't sufficiently say that they have left heart disease, of course, the most common is type group 3, meaning like they have some sort of chronic lung disease, or they have group 4 pulmonary hypertension with the CTEP. At a minimum, these patients should undergo some kind of pulmonary function testing with PFTs, looking at their the diffusion capacity from carbon monoxide, getting a high-res CT scan, and get a 6-minute walking test to at least see if there's something that points in the right direction for lung disease. Patients who are at risk for VTEs should undergo a VQ scanning and maybe consider pulmonary angiography as well. And there's always these patients who we don't have a clear-cut picture of what's going on, at a minimum, can consider looking at things that may work up for group 1 pulmonary hypertension, whether it's some kind of autoimmune serologies, HIV serologies, and liver function tests. And so right heart cath, I just wanted to review again, just the what is considered normal. And so, of course, getting a right atrial pressure, the pressures are normally between 0 to 8. A right ventricular pressure on average is 25/5, and a pulmonary arterial pressure, systolic pressures, 20 to 30s over 8 to 15, and a wedge pressure of 8 to 12. To get a good assessment of the right heart cath numbers, you want to make sure it's like N expiratory is when you want to be able to really collect the numbers. And so the ESC defines pulmonary hypertension based on the last year's guidelines as one, they have a mean PA pressure from a right heart cath greater than 20. This is new because in the previous guidelines suggested it was 25, but they have since decreased it. And specifically for pulmonary arterial hypertension, they have not only do you need a mean PA of greater than 20, but also have a wedge less than 15, plus a pulmonary vascular resistance greater than 2. You know, I specifically want to highlight the change in the PVR, because typically it used to be 3, now has decreased to 2, because I think there's a more catchment area by defining these lower like Woods units. And I think a lot of the studies have correlated that, you know, symptomatically, just from the pulmonary vascular resistance, we were able to help more of these patients. And so in the past, there's other hemodynamic factors that we would consider. One, like the transpulmonary gradient. You know, previously, also the diastolic pressure gradient was used, but one thing that the 2022 guidelines from ESC, they have actually taken away the use of DPG, just because there's data that shows that there's conflicting data on the actual prognostication of how beneficial the diastolic pressure gradient is, especially in regards to pulmonary hypertension to left heart disease. And so our patient ended up getting a right heart cath later, I think about a little bit later after she'd been optimized. One thing you'd appreciate, her RA pressure is about 5, RV pressure 63/3. The wedge was 9, and she had a PA pressure 62/21 with a mean of 35. And so with both the fix and the thermal dilution, her cardiac output was 6.4, and her cardiac output was 7.2 from the thermal dilution. And so the way that we calculate PVR is subtracting the mean arterial pressure minus the wedge over cardiac output. You know, if you multiply it by 80, you'll get it in dynes, but if you don't, you can end up getting the Woods unit. And so her PVR ended up being around 3.5 Woods units. And so based on her numbers, her ultimate diagnosis was pulmonary arterial hypertension due to connective tissue disease or group 1 disease. And one thing I wanted to highlight was the correlation between the right heart cath numbers and the echo numbers. So here, they are pretty on the spot. Like her right ventricular systolic pressure was like 63. We can see it was 63 here. You know, if we look back at the PI and diastolic value, it may have been a little bit of an overestimate since it was going to be in the high 20s. Here it's about 21. But overall, with a good echo, I guess the point is with a good echo, you can have a sufficient estimation of what patients' right-sided filling pressures are. And so just to take a step back, in patients who you suspect may have pulmonary hypertension due to group 2 disease, you know, they may have on the cusp pulmonary wedge pressures. You know, they may be right around 13, right around 14, but you're not really sure if this is from left heart disease or not. You know, one thing we know is that left side filling pressures can change whenever you change floating conditions. You know, especially for these patients who have been in-house, have been aggressively diuresing, you can actually unmask a cold left heart disease. And the way we do this is we can, one, either do provocation exercise testing. And sometimes a patient can have like a little bike where they are either supine or go upright for 20 minutes. And you can see that their wedge increases to greater than 25. This is considered a positive test. Or while you're in the lab, you can give a 500 cc normal saline bolus over 5 to 10 minutes. And if you see that the wedge increases to greater than 18 after this challenge, this is another way you can consider that this is diagnostic of left heart disease. And so briefly, I just want to talk about the treatment options for group 2 pulmonary hypertension as well as group 1. You know, we can further classify pulmonary hypertension. Is it before the pulmonary capillaries or is it post pulmonary capillaries? And so, typically true PAH is pre-capillary. This here, you can see there's like an increased resistance in the pulmonary artery itself. In patients who have heart failure or concern with the left side disease is actually further classified into, is it purely isolated just post-capillary, or is there a combined, is the left side filling pressures enough to like go and backtrack into this side of the circulation and cause a combined post and pre pulmonary hypertension picture. And so hemodynamically, we define this as having an isolated post-capillary pulmonary hypertension. The mean PA is greater than 20. The pulmonary wedge is greater than 15. And I'm sorry, this is supposed to be the Woods units less than 2. And then combined and pre-post is the same thing, except for the Woods units, the PVR is greater than 2 as well. And so this is a beautiful slide from ESC as well that sort of outlines the progression of the pulmonary hypertension due to group 2 disease. And so when it gets to the point where you're having an elevated left atrial filling pressures causing left atrial dysfunction, leading to congestion of the vessels, this can ultimately lead to vasoconstriction, and you get remodeling of both the arterial and venous systems of the capillaries, ultimately leading to RE dysfunction. And so this is sort of a spectrum of what's going on. When you have well-controlled left heart disease without the pulmonary congestion, you don't have any signs of pulmonary hypertension. But as it starts to get more congested, you have the beginnings of RVP uncoupling, you have isolated pressures on the right, and as it continues to get uncontrolled, it starts to ultimately affect the other side of the system, leading to what appears from a left ventricular phenotype ultimately to a right ventricular phenotype. And so ultimately the goal for group 2 pulmonary hypertension, we want to reduce the left side filling pressures whatever way we can. Whether it's a patient with heart failure, we have our GDMT, even with HFpEF, we have new medications for that. Just being able to decongest with diuretics is needed. Patients who have requiring resynchronization therapy that may help with improving the filling pressures. And anyone with valvular disorders, it's appropriate to treat this disease. One thing that we know is in patients who have both pre and post pulmonary hypertension, if you successfully unload the left side of the heart, you reduce the resistive afterload, the excess of like pulsatile load on the right ventricle, and studies have shown that the pulmonary vasculature can actually reverse remodel instead of having what we saw here, the remodeling, reverse remodel the other way, and start to look back to normal. There was a study in mitral stenosis where after they got their valvuloplasty, after 6 months of therapy, they were able to have normalization of the mean PA pressures, even if the baseline pulmonary hypertension severity was pretty bad. And even patients who underwent LVAD therapy, they were gradually shown to improve pulmonary heart, the mean PA in patients over time. They had both a high PVR as well as heart failure with reduced EF. And so systemic vasodilatation, this is especially important for patients undergoing heart transplant, because we want to make sure if we end up putting a heart in them, is their heart going to be able to tolerate the high pressures in the right and see if there's actually reversible. And so in these patients who have the combined pulmonary hypertension, they have greater than 2 WEDs, they have an elevated wedge, and at least a decent enough systolic blood pressure, we can give them, during a right heart cath, we can give them IV nitroprusside, and we can measure their cardiac output in wedge. And if we see normalizations of the PA pressures with a decrease in the pulmonary vascular resistance, this is just this can be a reversible precapillary component of pulmonary hypertension. And once they get a new heart, this could be beneficial, and hopefully the right-sided dysfunction can be reversed. In patients who do still have some persistent pulmonary hypertension, but they do have at least an appropriate response to a decrease in wedge, sometimes they can give inhaled nitric oxide as well. And this may also further identify some patients who could have a reversal component as well. So again, this is extremely important for our transplant population. I think there's an exciting treatment. I think when we have new toys, we want to see if it applies to everything. And so there's been discussion is, can we actually use group 1 treatment or for group 2 disease? And so the ESC guidelines very, very, very strongly recommend against the use of pH targeted therapies in this setting. There's been 5 trials based on the Cochrane review that showed the use of phosphodiesterase inhibitors compared to placebo in patients with group 2 disease. And just looking at the summary of the data, the quality of the data is low, very inconsistent. Maybe there's a benefit. The patients who had been using the phosphodiesterase inhibitors were able to walk 34 meters. And this is not even like during a 6-minute walk test. But overall, there was no evidence of mortality. And so, if you need to, I guess based on the ESC guidelines, is even though there's very, very limited evidence, so they could consider using a phosphodiesterase inhibitor in very, very, very select patients with pulmonary hypertension. These are the patients who have documented pre and post pulmonary hypertension. And patients who have been completely optimized from a wedge standpoint, and there's a low enough safety margin to use these phosphodiesterase inhibitors. And the symptoms are at least still present, even though there's like a normal wedge. And so the data is limited, but I think really the key is to try and offload the left side of the heart as best we can. And so just shifting gears a little bit, I just want to talk about treatment for group 1 disease. And so in patients with group 1 disease, they should undergo vasoreactivity testing. Of all patients with pulmonary hypertension, about 10 to 20% of them may respond to calcium channel blocker therapy. I think there's some patients, I think classically some patients with like hypertension or pulmonary hypertension, HIV may not respond. And so, there's a subclass of people who you may want to consider as vasoreactive testing. And so when you give like this nitric oxide while you're in the cath lab, if you can see that the mean PA decreases by 10 and to a value of less than 40, this test is considered positive. And they should at least consider trialing a calcium channel blocker for their treatment. And so overall, of all those patients, 10% do demonstrate a positive vasoreactive response. Unfortunately, how if they continue to be reactive, it remains to be seen. It seems like a very small proportion after they've been given actually do have a long-term response after the acute phase is over. There were some studies that after 5 years of people who were positive vasoreactivity and did receive calcium channel blocker, they ultimately had an improvement in their 5-year survivability. So typically what we would use is nifedipine and amlodipine. Shouldn't use those short-acting nifedipine. And you should reassess 3 to 6 months based on symptoms in the right heart cath to see if they're still responding. But ultimately, again, a larger population do end up requiring triple or double, triple PAH therapy. And really, we should limit these patients who can hemodynamically actually tolerate these therapies. And so now, I just want to just briefly talk about the 3 cornerstones of pulmonary arterial hypertension. Again, a lot of it after the remodeling of the vessel itself, the vessel is more constricted, it's been remodeled, it appears to be a little bit more fibrosed. And so there's 3 particular pathways that have been identified that can help at least slow the progression of the disease. And so one is like the endothelin receptor pathway. And so when you have endothelin 1, this can lead to vasoconstriction, and it's actually a pro-proliferative protein. And so the antagonists bind to endothelin itself and ultimately to the receptors of the smooth muscle cells, and this can result in vasodilation. What we can see from the pulmonary vasculature, as it's specific to that, because the pulmonary vasculature compared to like the other side is really, really rich in endothelium. And so their inhibition leads to a decrease in pulmonary vascular pressure this way. And so the medications that we can use is bosentan, ambrisentan, and mesletentan. In the middle, we have anything that interacts with a nitric oxide with a cyclic GMP pathway. And so what we know about nitric oxide, it's also a very potent pulmonary vasodilator. It goes to this nearby smooth muscular cells, activates GMP, can activate soluble guanyl cyclase, and ultimately leads to a cascade of events that ultimately reduce vascular tones. And so these are further subdivided into our phosphodiesterase inhibitors, such as sildenafil or tadalafil, or our guanylate cyclase stimulators, such as riociguat. And then lastly, our prostacyclins. The prostacyclins is typically released by endothelial cells inside, and can also lead to more vasodilation as well. And this is our Velitri, our Floban, our Remodulin, and Tyvaso. And so treatment and how we approach pulmonary hypertension is based on its WH classification again. And so patients typically who have class 1 symptoms, we don't typically catch them. We don't, a lot of times patients don't know they have pulmonary hypertension or symptom free. But if they have high risk features such as having a systemic disorder like connective tissue disease before they develop the pulmonary symptoms, sometimes they may start with a PAH specific monotherapy such as like sildenafil, especially if noted on their hemodynamics, they have elevated mean PA pressures. And so typically we'll see patients coming in with class 2 and class 3 symptoms. They're drug, and especially if they're drug naive, they like to be started typically on dual combination therapy with both a endothelium receptor agonist as well as something that affects nitric oxide cyclic GMP pathway. The Ambition trial really I guess confirmed the use of dual treatment compared to like mono treatment alone. Patients who are started on dual treatment, the combination of tadalafil and ambrisentan, showed there's a decrease in hospitalization, decrease in progressive PAH. Even though there's a little bit more adverse side effects such as headaches and nasal congestion, there were still, and the rates of hypertension, despite using both agents, was still pretty similar compared to like monotherapy. And then lastly, patients who come with class 4 symptoms, these are the ones who should require your IV Floban, your IV or your IV epoprostenol, and they're already going to typically be on a combination therapy of some sort. And it's in these patients that we should already start to consider for like a long-term evaluation. There's sometimes patients who, despite being on these medications, require a little bit more help. This is not typically used in the United States, but the creation of a right to left shunt can typically avoid some undesirable outcomes by able to divert some flow to the other side of the heart. But ultimately, again, the lung transplant is what should be considered when we get patients to this level of sickness. And so, at least summarizing what's gone on with this patient, as of like April, she feels better, less short of breath. She was started after the right heart cath number. She did get a vasoreactive test, which was ultimately negative. And so was started on tadalafil and ambrisentan. And since she's been started on those medications, still some fatigue, but improvement in her shortness of breath and her activities of daily living. And I just wanted to talk really brief about this new investigational therapy, sortacept. And so what we know about pulmonary hypertension is, not only is it just from reactions from the smooth muscle cells, but it's just because of its proliferative and anti-proliferative like disbalance, there's a need for further investigational therapies. And so, yes, we have the endothelin reaction, the endothelin 1 receptor agonist, the phosphodiesterase inhibitors, anything nitric oxide, but all those current therapies only focus on slowing the progression of disease and aren't really addressing the underlying problem. And so studies have shown that patients, especially with pulmonary arterial hypertension, there's actually a dysregulation in the BMP pathway. This is a bone morphogenic regenerative protein. And so when there's a dysregulation in the BMP cycle pathway, the anti-proliferative effects of PSMAD 158 is downregulated compared to the pro-proliferative. This basically leads to hyperactive activin leading to PSMAD 2/3, and ultimately this is a more pro-proliferative state, causing an increase causing worsening vasoconstriction, worsening the lumen size inside of the pulmonary artery itself. And so what sotatercept is, it's a monoclonal antibody that actually binds to the activin, blocks its receptor interaction, and thus decreases its pro-proliferative effect, and thus rebalancing between pro-proliferation and anti-proliferation. And thereby, hopefully, this could be a very interesting treatment for pulmonary hypertension, at least now more at a mechanistic level. And so there's a stellar trial that came out last month, double-blind multi-center study. It's a phase 3 study and looking at patients with class 2 and class 3 pulmonary hypertension. Half of the group received sotatercept, the other group received just a placebo. And so, their primary endpoint was one, how are they doing from the 6-minute walk test? And what they can see is the patients who got the sotatercept had an improvement, a modest improvement in the 6-minute walk test of 34 meters compared to the placebo effect. But really, it's some of the other secondary endpoints that were interesting. The patients who got sotatercept had a significantly decreased level of the pro-BNP. They had an increased improvement in their WHO functional class. And, interestingly enough, some of the side effects of sotatercept are, one, they have increased actual hemoglobin, but decreased thrombocytopenia. But there seems to be more side effects in the placebo arm compared to the placebo arm, compared to the sotatercept arm. So they're still early on in the phase, but this may be an exciting new treatment option for patients with very difficult controlled pulmonary hypertension. And so just take-home points, especially for us, pulmonary arterial hypertension is very rare. And left-side disease is about 50% of all cases. I think it's important for us to determine, is there sufficient enough left heart disease to consider less right heart caths? We can use the echo to suggest if there's pulmonary hypertension based on the tricuspid regurgitation values, and that the right heart cath is indicated, especially for left heart disease, if we can't really tell what the contribution is coming from it. We can use provocative testing in patients with borderline wedge testing, and treatment using traditional pulmonary hypertension treatment for group 2 is limited. We know that the cornerstones are the 3 treatments, and that sotatercept may be a novel agent that can target additional remodeling pathways for pulmonary hypertension. And so, I just wanted to take a little bit of time to thank Dr. Abdu, and Dr. Reeb. He's from Dr. Abdu, as we know, is one of our heart failure specialists, and really, really well-versed in pulmonary hypertension. And Fadi, he was one of my fellows back in ICU days, now is a pulmonary hypertension specialist over at Emory Midtown, helping me provide for the case. But I just want to thank you all for your attention. I'm happy to answer any questions you may have.
Thank you, Tim. Very good review, an important topic, and for the fellows, a frequently tested topic. All right, I'll open it up. Questions from the group.
Hi, good morning. This is Mahmoud. Tim, excellent job, fantastic talk, and you were able to finish on time. That's impressive. You covered a lot of a lot of material, and you did it very, very well. So I congratulate you on that. I don't really have questions, but I have a few remarks and kind of reminders to our fellows. highlighting a few things. Number one, the importance of detecting pulmonary hypertension and how it affects prognosis and mortality, especially in our patient population. As you saw, 70% of the 70% of pulmonary hypertension are actually belong to cardiology and are related to the heart disease. Therefore, we know for a fact that for patients who have pulmonary hypertension on top of their heart disease, their mortality is further reduced and their life expectancy is lower and their quality of life is lower. So detecting pulmonary hypertension here is important in prognostication. The other point I want to highlight is when you're evaluating pulmonary hypertension, especially in the cath lab and using right heart cath, this is where it becomes very, very important to be meticulous. For those of you who worked with me in the cath lab and doing right heart caths, I spend a lot of time in leveling, making sure the leveling and zeroing is appropriate, and then spending more time detecting a true wedge pressure, because that's very important. As you can see, that it has a lot of impact on your decisions later on. Make sure the waveforms are good. You're not over or under damped. We usually attempt to get a wedge sat to make sure that we're in the true wedge position. And then the third point I want to highlight is medications. And basically the take-home point right now, and that's what all the societal guidelines are suggesting, is that you're treating the underlying cause, and that's your heart failure or your valvular disease and so on and so forth. Really, the role for pulmonary arterial or pulmonary vasodilatory medications that are used to treat PAH really have a very limited role, if any. Maybe there's some data coming out on the use of sildenafil in a very narrow certain patient population. However, all the rest of the medications are usually not indicated, and I usually spend a lot of time in clinic taking off these medications then putting them back on, unless the patient has PAH, and then that's a whole total different story. So at the end, Tim, good job and good luck.
Thank you.
Tim, for the non-CTEPH related, maybe group 1 patients with severe, any role for anticoagulation, like prophylactic anticoagulation in these patients?
There used to be, I think, of the classic, there used to be data to support it, but really now it doesn't seem like there's as strong of an evidence. But I think way back when there was, but I don't think there's particularly a role as of right now for just prophylactic, unless there's some other underlying thrombo or systemic disorder that may lead them to be
without AFib, stuff like that. There was a time when we were doing that. I felt like we were doing that more just sort of prophylactically. Obviously, for CTEPH patients or folks with AFib or et cetera, it's a different discussion. But I seem to remember there was a time when you would consider prophylactic anticoagulation. It seems like we've gone away from that a little bit.
Right, and especially I think now that we know a little bit more, heparin itself, or some of the anticoagulation, at the endothelial level, sometimes that can cause a little bit more inflammation, and I don't know if that's going to worsen it or not, but I think it's just something to keep in mind.
Well, you did show that one slide, the diagnostic criteria, once again, for, with the mean pulmonary pressure greater than 20, Wood units greater than 2, et cetera. That is a key slide. I feel like that will be asked 3 or 4 different ways on the cardiology board exam. So every fellow, make sure you know that slide sort of forwards and backwards. So.
Yeah, and also they love asking you on the vasoactivity challenge and the criteria for a positive vasodilatory challenge. We're going to cover this in our, core conference talk on pulmonary hypertension in details, but that's another one. And something else they really like from pulmonary hypertension is the histopathological sign of PAH is the presence of plexiform lesions. And that's actually differentiate your PAH versus your combined pre and post capillary pulmonary hypertension from group 2 that's not reversible. In the latter, which is CPCPH, which is advanced and fixed, you'll have everything else: intimal fibrosis, all the inflammation, but you don't have plexiform lesions. But plexiform lesions are present in a hallmark of PAH. So that's another important point to highlight.
So, Mahmoud, you mentioned taking patients off of medicines in clinic, but I guess when we see these high pressures, most commonly we ought to be thinking about whether the patient has HFpEF and whether they should go on a SGLT2 inhibitor. Do you agree with that comment?
I agree with that completely, and usually I end up taking them to the cath lab, and like Tim mentioned in a few of his slides, if I'm really suspecting diastolic heart failure, I would not leave the cath lab without an answer. So I will either exercise them or challenge them with fluids and demonstrate that really their ventricle is non-compliant, and at that time they will be on SGLT2, they will be on MRAs, and we'll see if they have any roles for ARNIs. But you're absolutely right. Point well taken, Dr. Smith.
And just another comment, we'll see patients who have left heart failure, who have severe pulmonary hypertension that does not respond, so that they're not immediately a candidate for heart transplantation. But with left ventricular assist device therapy, if they have high pulmonary pressures and they don't have a super high venous pressure after treatment, they will actually do okay with an LVAD. And over time, those PA pressures generally normalize. And Dr. Alexander used to say that if you have a low blood flow state and high pressures, that impairs endothelial function, and low flow leads to low flow. And if you improve blood flow, that leads to improved blood flow. And so that's an interesting phenomenon. That was noted many, many years ago in severe mitral stenosis, that it could take several years for patients' pressures to come down after mitral valve replacement therapy in rheumatic heart disease. But just know that what looks like fixed pulmonary hypertension isn't always fixed.
Absolutely.
Okay, well, thanks again, Tim. Excellent review.
Thank you.
And thanks for everybody for tuning in. Have a great weekend. We'll see everybody next week.
The preceding program is copyrighted by Emory University.